You're listening to the Assembly on Pediatrics podcast, brought to you by the American Thoracic Society.
All right, well, good morning and welcome everyone. My name is Dr. Matt Wong. I'm a pediatric pulmonologist at the Children's Hospital of Los Angeles, and this is the ATS Breathe Easy Pediatric podcast. I'm joined today by my co-host, who I will let introduce herself.
Hi, everyone. I'm Shika Saxena. I'm a pediatric pulmonologist at the Children's Hospital of Philadelphia.
So this is one episode in a series of podcasts on advocacy, and today's topic is about inhaler-related advocacy, and we were very fortunate to have two awesome guests today, so I'll go ahead and allow them to introduce themselves.
I'll start. My name is Will Feldman. I am an adult pulmonologist and intensivist and health services researcher with a focus on FDA regulation, pharmaceutical pricing, and have thought a lot about barriers to inhaler access.
And I'm Robyn Cohen. I'm a pediatric pulmonologist and health services researcher at Boston Medical Center and Boston University. And I also have a population health role around asthma quality for one of our state Medicaid managed care programs.
Awesome. So again, welcome to the both of you. We are really grateful that you guys can join us today. Just jumping into it. So I think both of us are curious to know how each of you independently got involved in inhaler-related advocacy.
I started thinking about these questions when I was a fellow, and I have a distinct vision of the poster with all of the inhalers on the wall in my clinic when I was starting fellowship, and that was in 2017. There was not a single generic inhaler. And I think during my fellowship, I had this series of experiences that probably a lot of people have, which is seeing patients who can't afford their inhaler, some of whom don't actually want to talk about it. They're just not taking it and perhaps are embarrassed about talking about not being able to afford their inhalers. And I just started asking this series of questions that, again, probably a lot of people have found themselves asking. How are these products so expensive, given that they've been around for decades? Why, when you look at a chart in 2017, is there not a single generic inhaler on the US market? That led me to do a series of studies really looking at the intellectual property around inhalers, looking at pricing around inhalers, which ultimately propelled me into taking on an advocacy role to try to help address these barriers for patients.
So my involvement with inhaler advocacy really started organically around the Flovent discontinuation. As I mentioned, I have a population health role for a Medicaid program. And so I knew that Flovent was being discontinued back in August of 2023 and had spent most of the fall trying to prepare my own practice, the hospital, and the health system for this big abrupt disruption in care, and realized that this really needed to be an all hands on deck situation because of the magnitude of how many people were being affected. And so in early December, I actually put together this long how-to Twitter thread for patients, caregivers, providers, practices, health systems about all the things that they needed to think about in preparation for this. Really just as an FYI. And I was contacted by a national news reporter for an interview, which led to other interviews. And I think it was after that, actually, Will, that you reached out to me because the Senate Health Committee, the Committee on Health, Education, Labor, and Pensions, had opened an investigation into inhaler patent practices. And we're interested in talking with someone who had an on-the-ground perspective. And I was really honored to have the opportunity to share what our experience was like and felt empowered to then reach out to the government advocacy office at my own institution to see who else in government I could talk to about this, and actually worked with someone at the ALA, with my colleague Christy Sadramilli at Johns Hopkins to write an op-ed. They taught us how to pitch a story. I felt empowered to start pitching stories to reporters, and it all just kind of took off after I wrote a Twitter thread. And I spent most of 2024 dropping everything to talk to reporters, to talk to health staffers, in Congress. And it was much easier to engage with people than I thought it was. You just have to do it, and people are happy to talk to you. So,
And you write great Twitter threads, for the record.
I left Twitter, but I'm on Blue Sky
Me
now.
too. Me too. I know. I miss those.
There was a great
those
community
threads.
on there.
Yeah.
But that was like social media was a very effective way to engage with people and for reporters to find me and my colleagues who are interested in this issue.
That is so cool. That is so interesting how all of it started with a Twitter thread, and you probably didn't even think that it would end up here. So that's incredible.
No, like within the hour of me pressing, post, a reporter from like a national media outlet reached out to me wanting to talk. So, but then there were a lot of lessons learned about like speaking to the communications and media office at my institution. And there, I definitely needed some training. I was very green about how to speak to the press, about how to speak to, health staffers to make the time that I had the most high yield as possible. So there was definitely a learning curve. So I was grateful to have that also.
Yeah. And just from hearing both of you speak, and that's interesting, Dr. Feldman, how you reached out to Dr. Cohen. Do you feel like there have been strengths from having both the pediatric and adult mindset in working with some of these issues?
I definitely have. I find myself reaching out to Robyn and Christy a fair bit around pediatric inhaler issues and just more general about pediatric pulmonary issues. And I would even make a broader point that what I have found through all of this work is just a lot of value in connecting with folks across fields. So one of the things that would be great to talk about is sort of the environmental impacts of inhalers. And so I've started connecting with folks who do a lot of environmental work and have myself gotten more interested in the other spheres of climate related issues outside of inhalers. But my kind of in was writing about inhalers, and I found those sorts of relationships to be incredibly useful. And the more I've done, and I think probably Robyn, you feel the same way, the more that you've done, it feels like you meet people in different settings, whether at conferences. I've presented some at the FDA and have met folks that way, that you start building this community of like-minded folks who are interested in kind of moving the needle on some of these issues.
Exactly. I think that's also, we have networks, like we have, not only do we have our own voices, but we have the connections through our networks. So at one point I was speaking with a health staffer to some senator and mentioned that I'm part of a New England Pediatric Pulmonary Consortium with over 100 pediatric pulmonologists. And so we could get a letter together with 100 signatures at the ready, if that would be helpful in any way. And that letter was cited by the Washington Post. It was used in a press release about an investigation that was opened. And so we have power, not only as individuals, but as a group. And that was such an exciting surprise to learn that how much our voices do matter and are valued.
I think we sometimes take it for granted, all of this clinical experience that we've accumulated, all of these networks that we've built with fellow physicians. And I totally agree. I'm always surprised at the response from folks on the Hill, or folks who are in government more broadly. How receptive they are to hearing from clinicians who have been dealing with these issues on the ground.
Absolutely.
And so you'd mentioned started to talk about some of the issues we talked about, like the discontinuation of the brand name Flovent, moving to the generic Fluticasone. Are you still kind of seeing the aftermath of those effects?
I continue to be disappointed by the response. And in addition to meeting with media and people on the Hill, I met with some executives in the involved pharmaceutical companies and with some people in the pharmacy benefit manager, at a pharmacy benefit manager. So there's 3 pharmacy benefit managers that provide prescription benefits to 90% of the population. And so they're the ones who really are deciding what meds are covered. And the general response that I get is like, oops, sorry, we didn't know this was going to be a problem, and it's not my problem, it's the other guy's problem, or it's the other part of the chain's problem. So the pharmacy benefit manager will tell you that, well, no, it's not my problem, it's the pharmaceutical company's problem. And the pharmaceutical company will say, well, it's not my problem because I'm not making the product anymore, it's this other distributor that's the problem. And there's so much passing of the buck. And it has made it just, yes, I do feel like there continues to be fallout from this that is just frustrating.
Yeah, I agree. I feel like we're still seeing that in our clinics too, that patients are not necessarily getting their inhalers or the right inhaler, or it's being switched with something that's not necessarily a good substitute. So definitely hear you. And I know there's so many issues around that.
It's the whole thing is so frustrating because it it really is a problem created by many actors, but this sort of finger pointing of it being somebody else's fault, I feel like is unfortunately very, very common when it comes to these pharmaceutical issues. It's very complicated. In the case of Flovent, you had a piece of legislation that went into effect that caused companies, including GSK and others, to either drop their list prices on these inhalers or pull the product from the market. They pulled the product from the market, and now you have an authorized generic that PBMs weren't always covering. And so it's easy to point a finger at the PBMs to say, why aren't they covering the authorized generic? Perfectly reasonable to ask that question. It's also perfectly reasonable to ask the question, why weren't there more generic inhalers to begin with? What was GSK doing that was limiting generic competition over decades? Fluticasone came to the market in 1996. So that's a long time ago, right? So I find these conversations frustrating because in a way, everybody is right. The other side has done something wrong, but it is, it can be frustrating when you don't see folks kind of acknowledging their own role in this, this situation that we're now in.
And there's also just a complete lack of communication about how to navigate the system. And so one of the PBMs told me that they would automatically cover fluticasone HFA for any patient for whom a request came in, a formulary exception request came in that said patient needs an MDI because they need to use a spacer. But that's nowhere on the website. That's not communicated to anyone at any time. And so no one knows that this is the case. This is the response when executives are asked about it, but there's no way for the provider on the ground or the patient on the ground or the pharmacist, the dispensing pharmacist to know that this is the case, that, a simple one-liner. And if that's the case, then why require a prior authorization at all? Why not just cover it in the first place?
And if it's hard for Robyn, a pediatric pulmonologist who specializes in the management of these, of patients with asthma, like just think about the, pediatricians out there who aren't pulmonologists, primary care doctors, like this always kind of, you have to remind myself as an adult pulmonologist, the vast majority of inhalers are being prescribed by generalists, not by specialists. And if it's hard for specialists to do this effectively, it's that much harder for generalists.
That's a really good point. And we're starting to say how, most of our pediatric patients are on the MDIs. And I wanted to bring up what you were talking about earlier about with climate change, how it seems like there's now this gradual push away from the MDI towards the DPI, with some of the implications of HFA. Did you want to go into that a little bit more?
I'd be glad to, and I'm curious, for your take, Robyn. I mean, it's complicated, and we need to sort of talk through all of the facets of the issue. So HFA inhalers are potent greenhouse gas emitters. 3% of the carbon footprint of the National Health Service in the UK is related to inhalers. MDIs have 20 times the greenhouse gas emissions as DPIs. So I think it is great that we are addressing the problem of emissions. One way of doing that is through switching from MDIs to currently available inhalers like DPIs or soft mist inhalers. But of course, that won't work for everyone. There are newer inhalers with novel propellants that have made it through clinical trials that will hit the US market fairly soon. And one thing that I am very worried about are the costs. We saw during the CFC to HFA transition that patients faced much higher out-of-pocket costs. Companies on albuterol alone made $14 billion in the transition from CFC to HFA inhalers. They are poised to make similarly large sums of money in the transition from HFA inhalers to inhalers with novel propellants. And so I think as pulmonologists, this all puts us in a very tough position. I think we should all want to address climate change. We want to do our role. We want patients to have access to inhalers that aren't super expensive. And the question is, how can we do that for a 5-year-old kid who needs an MDI? How can we make sure that what we are prescribing is good for the environment, isn't insanely expensive, so that the 5-year-old can get the MDI? And I'm very pessimistic about what it's going to look like over the next decade. I think we could have this podcast again in 10 years, and we will be talking about high prices for inhalers, for MDIs with novel propellants, including albuterol, which was first approved in 1981.
Right, because that allows the company to have a new patent on a new product because the delivery device is different than the previous delivery device. But the other issue is that there are no ICS formoterol inhalers available in the United States in a dry powder form. So now, the GINA guidelines, the NIH guidelines are clear that guideline preferred therapy is with combination ICS formoterol inhalers. And if I'm going to provide my patient with guideline preferred care, then there has to be an environmentally preferred option available. And all but one of the clinical trials for SMART and AIR therapy were done with DPIs, including the one trial that included children back in 2007. That was with a DPI inhaler. And the Symbicort has been available as a DPI across the pond for decades. But I guess there's no financial incentive for them to go through the FDA process to get it approved here. I'm not really sure, but I'm not going to not give my patient the guideline preferred care that they need because the inhaler isn't available in a dry powder form. That doesn't seem right. That doesn't sit right to me. And I also don't think it helps because then it requires that they need to use more albuterol. I think the switch to a SMART, a single combination regimen ends up sparing greenhouse gases because you're using fewer inhalers and fewer inhalations. So there's some work to do on the industry side to help us provide care in a responsible way.
I couldn't agree more. If you look at the overwhelming majority of emissions are from short-acting beta agonists and ICS LABAs, and so many of these people getting short-acting beta agonists really should be getting, I should be getting an ICS LABA, but we can't. There is no dry powder ICS LABA that's suitable for rescue use in asthma, available in the United States. And I just want to underscore one point that Robyn mentioned, which is, why don't we have a dry powder? Why isn't there dry powder Symbicort on the US market? It's available elsewhere. Why hasn't AstraZeneca brought that to market in the United States? And you can't help but wonder if the reason isn't that they recognize that the patents on that dry powder delivery vehicle are expired. There is a lot of money to be made through release of other products besides a dry powder version of Symbicort, including AirSupra, which is a new product on the market that is albuterol with an ICS. So they're making money there. They're going to make money in a few years when they get a version of Symbicort approved with a novel propellant. So we're talking about another decade or more of patent protection for expensive inhalers. Why undermine that market with a dry powder version of Symbicort that would be cheaper when there's all this money to be made? And I think it's really unfortunate that this is where we are. But I think that is where we are headed. We will have a low carbon version of Symbicort available on the US market that is expensive, that we will all want to prescribe because it is an MDI that isn't bad for the environment, that is also guideline concordant for our patients, and it will be a lot of money for AstraZeneca.
Yeah, I think that's a really good point. And it's a challenge for us at this point with wanting to do right by the patient with guideline-based care, but also wanting to do right by the environment, balancing that, and then with what's even available to us, which is limited and really not ideal at this point.
It's yes, exactly. And you see a lot of these articles sort of, physicians and patients only have so much control here, right? Only certain things are covered on formularies. Only certain products are available on the US market. And it's a lot to ask of an individual clinician to balance all of these competing things when in fact it's out of their hands. In a lot of cases, right? They can't prescribe the thing that they want because only something else is on formulary, and maybe that's bad for the environment, or it's not their first choice for the patient, but that's what's they're being told they have to prescribe.
Do you guys have any good, or not just good, but just recommendations on resources for people listening to educate themselves more on a lot of the topics that we've just been discussing? I'm just finding myself really absorbing kind of everything that's been said, and I really want us to go into depth more, but I think just this isn't the best medium to do that.
I would say start by reading anything that Will has written on this issue around patents and medication device combinations. It is enlightening and shocking and enraging. And I think will inspire you to find a way to get involved, because the fact that there has not been a new product introduced on the market in a new drug class in 50 years, and the fact that all of these are patent protected is just absurd. And so I would start by reading anything that Will has written.
That's way too kind, Robyn. I appreciate that. It's a hard thing to get familiar with because it's such a complicated issue. To really go deep on the things we're talking about, you sort of have to understand how PBMs work and how drug companies are incentivized to get patents and how patents are listed with the FDA and this book called the Orange Book. And you quickly find yourself kind of getting caught in the weeds on some of these topics. But I will say there are a number of excellent healthcare reporters out there, some excellent climate reporters who've covered some of these issues in really helpful ways. So I would also, for folks kind of interested in anything that we've talked about, just search for, Flovent discontinuation, and you'll find some really good reporting on what has happened, many with great quotes from Robyn about sort of how it's affecting patients. But I don't know. I'm always amazed at what great journalists can do to pull out the important pieces of stories that are familiar to us but not familiar to everyone. So I would encourage folks to sort of start reading those news stories.
But also for the physician on the ground who's in the exam room with the patient on a regular basis, I found it really hard to keep everything straight. And so in January of 2025, I just went onto the websites of the three big PBMs, Optum, Express Scripts, and CVS Caremark. and looked up on their formularies what's covered, as well as the like major insurers in my region. So fortunately, Massachusetts, our Medicaid plan has a unified formulary. It has one formulary that I need to know. And so I just made myself a table that's saved in my phone so that when I'm in the exam room, and the question to ask the patient is not what insurance do you have, but do you have a card that you have to present when you go to the pharmacy to get your prescriptions? Because often the answers to those questions are different. And like I said, 90% of patients in the country are covered by one of the three big PBMs. And so you're going to get a lot of, bang for your buck just by doing that. And it probably took me like an hour to make that table for myself that I have looked at a million times so far in this calendar year. So a little bit of an upfront time investment that has saved me a lot of headache.
Yeah, really helpful recommendations. I guess another question to ask is more lessons learned from your experience. What were some of the challenges or barriers that you guys encountered, even at the initial stages and even right now as well, that might be helpful for anyone that is interested in getting into advocacy?
I'll just start by saying Christy and I wrote an op-ed about the inhaler crisis, and we had to pitch it to a lot of places, which was a little, humbling for us. And it didn't mean that what we had written wasn't of value. It just, it depended on like the priority of the media outlet for that particular week or whatever. But we were lucky to have a media specialist from the American Lung Association, like continuing to encourage us to keep going. And so it eventually found a home, but that was it was our first attempt at like writing one of these. So I would say just like keep going and work with someone who's done it before, because I found that really helpful.
I'll say, I guess one sort of piece of optimism and one piece of pessimism. My piece of optimism is I've been amazed at the power of academic research that you think about, you find some interesting question in the clinic, something that's troubling that you don't quite understand, that can lead to answering questions in research articles that you publish in medical journals that becomes a catalyst for reporters to start covering it, that can become a catalyst for politicians to start looking into it. And what I've observed over the last 5 years is that these academic pieces really do go a long way. They end up getting cited by policymakers, they get cited in media outlets. So I would just encourage folks to think about turning these sorts of questions into research projects that get published and then going from there to kind of do the outreach with policymakers, with media outlets to promote the work. So that is my optimistic lesson learned. My pessimistic lesson learned is that there are a lot of vested interests in healthcare, from the pharmaceutical industry to PBMs to hospitals where many of us work. There are a lot of really, really vested interests with massive financial incentives for things to go one way or the other. And they have powerful lobbying arms. There's just a lot that maybe isn't visible beneath the surface that is happening with these stakeholders to push against reform. And I think a good example of this is Robyn mentioned earlier, the Senate Help Committee launched this investigation into patenting practices into the inhaler manufacturers, and three of the big four manufacturers, Boehringer Ingelheim, GSK, and AstraZeneca, all announced these $35 out-of-pocket caps. And that sounded really great. And I think a lot of people were excited about those $35 out-of-pocket caps on inhalers. But you start to look under the hood, and now we're starting to get data to see what's happening. These were announced about, I don't know, a year or so ago, and they went into effect starting last summer. And they don't apply in Medicare and Medicaid, right? They only apply in commercial plans. They only apply to brand name products. There's been a big shift towards what are called authorized generics, which the brand name companies actually either produce or license to a third party to produce that aren't independent generics. So those authorized generics aren't eligible for the coupons. And the only point in bringing this up is that even what can feel like a win, the pharmaceutical companies know that in fact it's actually not going to undercut their bottom line too much, and so it's a reminder, I think, of just how powerful some of these stakeholders are.
And even though GSK announced a $35 cap, because they no longer are the ones who sell brand Flovent, now it's manufactured and distributed through a generic company, this $35 cap doesn't apply to the generic Fluticasone product. And so I don't think, with the exception of Symbicort, there were no other products for any of those three pharmaceutical companies that are targeted to a pediatric population, which was.
Yeah. And Symbicort, I mean, that's a perfect example. Flovent has an authorized generic, so GSK benefits from the sale of generic, but it's the authorized generic version of Fluticasone. There's no $35 cap. Same with Symbicort. And we've seen an uptick in use of authorized generics over the last year or two, maybe for reasons unrelated to this $35 cap. But just to point out that it's not really hurting their bottom line very much.
One other small concrete lesson learned is I was not aware that my institution had a government advocacy office. And I'm sure we are not alone in having a government advocacy office. And the person who's in charge of federal advocacy actually has come to every one of my, like, just lurking in the background. And then after the fact, like, gives me a little feedback. Or will often chime in with some helpful piece of information, or will model, like, ideal approaches to follow up for me. And he knows all the health staffers for all of the senators and Congress, of the representatives in my region. And so was able to easily connect me with people. And so if advocacy is something that you're interested in, I would say lean on your government advocacy teams at your institutions, because they have connections that I would have never imagined. And it's been really fun and informative. So
thank you so much for sharing all of these pearls with us. It's so interesting to hear about your experiences and, take away little bits of wisdom. So we appreciate it.
Thank you so much for having us.
I hope we haven't given too dark of a picture here, though. I don't know.
No, I don't think so. I think it was a super insightful conversation that we've all had.
Well, the other fun thing is that once you make these connections, like now that I've made these connections on this specific issue, the people on the Hill are reaching out to me about other issues because they know I'm responsive. They know I have a network, a pretty large, national network. And so if they need to speak with someone in a specific state that they're particularly interested in, they'll reach out to Christy and me because they know we can get them in touch with people. And so once you become sort of a reliable source for them, and it's in these times, it's nice to feel that we're useful in some way, shape, or form.
And I think that responsiveness is so important. Like the timeline for folks in government or folks in news media can be quick. Things are there. It's not like submit to a journal and wait a few months and revise and right. Like things can be moving fast. And so I think responding quickly can be very helpful to sort of be working on the timeline that others are working on, that maybe we're less accustomed to in academia.
Yes, very much so. Yeah, we'll pretty much drop everything because there's a press conference that's happening next week and they need someone from this state who's had this experience. Who can we put them in touch with? But it's nice to feel helpful.
That's nice. And it's nice to make those connections too, to actually feel like somebody that will reach out to you and that you could reach out to them, and to kind of form those connections.
Yeah. And we provide regular updates when something gets published, when there's been some nugget of success in something, or some new data comes out. The EPIC research team published it's not perfect, but some data about the impact of the Flovent discontinuation on acute healthcare utilization for patients who had previously been prescribed Flovent. And as soon as that came out, I circulated that to all my connections on the Hill, because who knows if that's useful information that they could use to compel some investigation or, put pressure on somebody to do something. And so, as Will said, like, data and scientific publications are really useful and appreciated when they're shared.
Any final thoughts before we wrap up? All right, guys. Well, thank you again for joining us. I think I feel like I learned a lot from this conversation myself as well. And thank you again. So.
Thank you so much. So helpful for us.
Thank you. I guess I should have said this before, but I certainly am happy if folks watching this or listening to this ever want to chat about policy, advocacy, any of the things we talked about. I'm always happy to sit down and have a conversation. I continue to do a lot of research in this space at the intersection of health policy and pulmonary medicine. Always glad to meet with fellows, trainees, because I think at the end of the day, we're all just trying to do better for our patients, make a better healthcare system, because there's so much that is broken. So anybody that is interested, always glad to connect.
And I would like to put in a plug for the advocacy subcommittee of the PEDS Assembly in ATS. We have a really active advocacy subcommittee that's working on a whole host of issues with a really activated group of pediatric pulmonologists and some primary care physicians and others in our group. And so definitely reach out to me about how to get connected with the advocacy committee, because there are some amazing humans in that group.
We can definitely attest to the amazing humans in the advocacy subgroup. All right, everyone. Thank you again.
Thanks so much.
Thank you.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.